Golden notes: polymyalgia rheumatica, PMR. Pathophysiology overlaps with temporal arthritis. 30% of patients also have giant cell arthritis. Histology shows vasculitis with giant cells, characteristically skips certain sections of affected artery whilst damaging others. Muscle bed artery is affected most in polymyalgia rheumatica. Epidemiology occurring in patients age 50s or older, more common in women. Features typically patient more than 60 years old, very rarely seen in the under 50s, usually rapid onset, less than 1 month. Typically presents with pain and stiffness of the shoulder and pelvic girdle muscles. Aching, morning stiffness in proximal limb muscles, not weakness. Pain and muscle stiffness worst in the mornings. Mild polyarthralgia, lethargy, depression, low-grade fever, anorexia, night sweats, weight loss. Investigations: ESR more than 40, the next best investigation. A high ESR would prompt immediate treatment with steroids. Raised CRP: alkaline phosphatase is an acute phase reactant and is raised in approximately a third of patients with polymyalgia rheumatica. CK and EMG are normal. Reduced CD8 T cells, normochromic normocytic anemia. The differential diagnosis: giant cell arthritis. GCA and PMR frequently coexist. Cranial symptoms including headache, jaw claudication, and vision symptoms are typically absent in patients with PMR. PMR typically has less prominent symptoms than GCA. Treatment: prednisolone, 15 mg once daily. You will see a dramatic response. In fact, response to a moderate dose of steroids can be useful in confirming the diagnosis of PMR. The maximum dose of prednisolone should not exceed 20 mg once daily. Patient should report 70% improvement in symptoms within 3 to 4 weeks, and inflammatory markers should have normalized by this point. Calcium and vitamin D supplementation should be initiated for all patients with PMR who are starting corticosteroid therapy. Bisphosphonates should be added for long-term steroid therapy. The usual starting dose is 15 mg prednisolone per day. Patients should expect relief of symptoms within 24 to 72 hours. One of the best tests for polymyalgia rheumatica is how patients respond to corticosteroid therapy. Tapering should be guided by clinical response. The dose should be increased if symptoms are not well controlled within 1 week. The effective starting dose should be maintained for 2 to 4 weeks after the patient becomes asymptomatic. Generally, the daily dose can be lowered by 1 to 2.5 mg every 2 to 4 weeks to find the minimum dose needed to maintain symptom suppression. Once the patient is reduced to 10 mg per day, the daily dose can be tapered by 1 mg every 4 weeks. Approximately 50 to 75% of patients can discontinue corticosteroid after 2 years of treatment. Methotrexate and azathioprine, if symptoms relapse when the dose of prednisolone has been reduced below the current dose, then continue the current dose of prednisolone and start methotrexate. Used in patients with corticosteroid intolerance or as corticosteroid-sparing agents. These are generally reserved for patients in whom it has been difficult to reduce the prednisolone after prolonged high dosage, for example, 10 mg or more per day for more than a year. These agents should be added to the prednisolone initially, but with a view to slowly reduce and withdraw prednisolone. As with steroid therapy, azathioprine or methotrexate can be discontinued if there has been sufficient response. Prognosis: rapid improvement often occurs within 24 to 72 hours with low-dose prednisolone. This was provided by the SSSM Study Smart Series for Mrcp, your easy way to easy pass. Don't forget to follow us on Facebook, Telegram, and YouTube channel. Thank you very much.